Things to tell you. HAPS test, the comprehensive test. I will probably, I think later today, be posting an announcement on Canvas for you guys about where to go to sign up for it. You cannot change the day that you signed up for. So if you want to change it, you need to change it by like 3 this afternoon, because I need to send them a complete list of the day that the date or the time that you could deal with that through the testing center. But here's what HAPS does. They only send tests for X students on X day. And then they won't open them up again. And you can't ask me, and I won't do it, and they won't let me after that. So if you want to change the date, go change it right now, okay, before you leave class. Go ahead. It's going to be just there during the day, and you sign up the time. Okay. Yeah. So I'm going to put, no, I'm going to post a link for you to tell the testing center when you're going to take it, but you can't change the day. You can change the time, because you haven't committed to that yet, yeah? Okay, but I can't change the day, and HAPS won't let me, and so don't even ask. So go change the date right now if that's not the day that you want to take it. But it is just for bonus, so just kick ass, be brilliant, no stress, okay? Use it as a trial for your final exam. The other thing that I want to tell you, Wednesday. Everybody wants me to cancel class on Wednesday. I can't do it, FYI. Somebody in our department canceled all of their classes last Wednesday before Thanksgiving and almost got fired, even though she had tenure. I would like to stay home too, but I have the job that I have and I like it. So I'm going to be here, and we're going to learn about the male reproductive system. So some of you guys could probably benefit from it. I don't know, right? If you're going to encounter a penis, you might want to know how they work, whether it's your own or somebody else's. Okay, so everybody good? What else do I need to tell you? Is that it? And then your last lecture test is the Wednesday before finals, which I don't know what date that is. And then your final exam is the Monday of finals, yes? Yeah? Does that sound all familiar? So you're almost done. Like so close, so close. And so am I. Okay. So what we did last time was we figured out how you got to be a sex at all. Yeah? Okay. I'm going to go through that just briefly one more time just to make sure it's clear, and then we'll get into the adult female reproductive system. So just because this takes a little while to stick, okay, what happens is, of course, we started out with all of the pink ductwork and all of the purple ductwork. The pink ductwork, one more time, they're called the Mullerian ducts or the paramesonephric ducts. I think Mullerian is easier to remember. If those complete their development, they will become oviducts and a uterus, and they will connect to the blind vagina that everybody started out with. Everybody starts out with what could be a blind vagina. However, in the male situation, if the purple ducts complete their development, they will become the vas deferens, the seminal vesicle, and they'll contribute to the prostate gland. Good? Okay. And then what we learned last time was that maleness in humans, it's not the same in every mammal even, is not the absence of testosterone, absence of estrogen, it's the presence of testosterone. So what happens is at a certain point in development, if there is a shot of testosterone, which will happen in a normal anatomical male or along this pathway, because what happens is along this pathway, to become a normal anatomical male, just a typical anatomical male, SRY gene turns on, and the SRY gene says, hey, gonads, we're going to be testes, yeah? And then they go down the path of becoming testes. And then as they start to do that, they will secrete MIH, which is Mullerian inhibiting hormone, which will cause degeneration of what could be the female ducts, right? Then continued development in communication with the placenta will cause secretion of androgens, which will complete the male development. Does that make sense? So you actually have to flip 3 switches in order to become a typical anatomical male. That's why they always say that the default anatomical sex in humans is female, right? So if you don't do much of anything, your external genitalia will end up looking like that, at least more like that than like this. Good? Okay, So as we are going through the female reproductive system anatomy, I want to make sure that you always are able to revisit the homologous structures, males and females. Cool? Okay, so let's start with the female reproductive system anatomy, and let's acknowledge some truths about this. First off, people do not tend to know very much about the female reproductive system anatomy, and women are almost invariably worse at it than men. For about the last 10 years, women have performed worse on this last test when I always give this picture and have you label it. You guys tell me that the clitoris is down here, and if that's why you're wiggling, that's not what you think it is, okay? So it's not over here, it's not down here, it's not in the urethra, that's not where it is. You will have this structure, you will label that structure on your fourth test, I promise, okay? So why do women tend to do worse? I think we have been culturally biased against learning female reproductive system anatomy, both strictly culturally biased. We will see that, for instance, with the clitoris. Depending on whether we were in a very conservative time or not, they actually removed the clitoris from Gray's Anatomy in the 1950s, put it back, removed it again in the 1980s. In addition, all of the female reproductive system, most of it's internal, right? So you can see testes, you can see a penis, yes? You can't see a vagina, right? You can just see the vaginal orifice, you can't see all of the internal structures. So the reason I'm telling you this is because sometimes you think you know and you don't know, but you should know and you're gonna know because I'm gonna test you on it, okay? So the female reproductive system anatomy. And the other thing is the physiology of the female reproductive system is like the male reproductive system plus one extra function, because both male and female reproductive systems have to produce gametes, eggs or sperm, right? And hormones, androgens or estrogens, right? And progesterone. But then the female has an extra function, and the extra function is that she must be able to prepare for and support a developing embryo and fetus, right? So before we get into the nitty-gritty of the anatomy, I want to just acknowledge the physiology a little bit. So I'm going to talk a little bit about the menstrual cycle and what's actually going on. But the physiology is really, really complicated. I'm going to do a super simple version of what's going on with the physiology. And I don't test over this in a lot of detail, but I do want you to know the basics of it. So if we look at just the basic anatomies, of course, this is the ovary and this is the uterus. So what the menstrual cycle is, to way oversimplify it, is the top box is the ovary and the bottom box is the uterus. And the ovary is the boss in the female reproductive system. What the ovary does is tries to tell the uterus when it's time to get ready for a possible implantation and pregnancy and when one could not occur. Does that make sense? So if we go through the process, and we'll look at this in detail in just a second, if we go through the process of meiosis and then ovulation, right? That makes sense? When you are getting ready and you're about to ovulate right here, one thing that correlates with this is an increase of the hormone progesterone. Progesterone is easy to understand because it's progestation. Progestation? Yeah. So what it does is the ovary talks to the uterus, among other places, and it tells it that it is almost time. It's almost time. And what do you think the uterus responds by doing? By thickening, right? By increasing vasculature and increasing tissue in the wall of the uterus, right? In preparation for the possibility of an implantation. Does that make sense? So, ovulation is going to occur, it's communicating, this is thickening, right? If implantation did occur, what would happen to the progesterone level during the entire healthy pregnancy? It would stay high because it's progestation, yes? It would stay high. But of course you don't get pregnant every time you have sex. Thank goodness, yes? So what happens most of the time is that ovulation occurs, right? For whatever reason, either fertilization or implantation or both don't occur. And then you give yourself a window in between ovulation and when implantation could not occur. Let's say a week, it's variable, okay? A week between ovulation and implantation could occur. When that window is passed, your ovary says, hey, not this month, and it stops progesterone secretion, pretty dramatically, actually. And as it stops progesterone secretion, it stops telling the uterus to get ready anymore. And so what does the uterus do? It sheds off the lining, right? It menstruates the lining and starts the whole process over again, right? Every single time. Why is it so important that that lining is nice and thick? Because remember, when we talked about the placenta, it is right at the site of implantation, you are going to develop a really rich capillary flow that will eventually become the placenta, right? So you get a nice, rich capillary flow. So this is not fluid, this is vascular tissue, right? Vascular tissue develops every single cycle, right? So this is the nature. Now, it's way more complicated than this because it also has to do with how much estrogen you have at certain times. And all you have to do in order to make a woman less likely to have implantation is discoordinate what's going on with the ovary with what's going on with the uterus. So lots and lots of different ways to do contraception. One of them is to confuse her hormones enough that she doesn't ovulate. Yes? That's how some hormonal birth controls work. Actually, all of them work that way, but some of them work in different ways, progesterone, estrogen. All you have to do is make it uncoordinated so it won't cause ovulation. The other way, of course, stop the sperm from getting in there. Literally every pregnancy starts with male ejaculation, yes? Not with female orgasm. Let's all remember that, every single one. Okay, or you could just make the uterus inhospitable to implantation, which is what a copper IUD does. Yeah, it doesn't stop ovulation, doesn't stop fertilization, but prevents implantation. And then the Mirena IUD, the one that's plastic, right? And it goes up in the uterus, it actually kind of does a combination. It both makes ovulation less likely and implantation less likely, right? It does both. And they don't even actually know which one it does more. Like they've looked at the fizz, they're like, it just does both. It seems to work really well. Okay, so that's a menstrual cycle, just a little bit about the menstrual cycle. Now let's look at the female adult anatomy, and let's talk about the external anatomy first. All right, so the external anatomy is the vulva. And either in middle school you dreaded looking at anything like this. My son would murder me if I put this up and he was in the room. But if I wasn't in the room, he might be thrilled. Okay, so the female external anatomy is called the vulva. So first off, vulva does not equal vagina. This is not a vagina. This is the vulva. The other really commonly historically used term is pudendum, which we're trying to get away from now because it is the Latin for shameful, right? They call the female external anatomy the shameful spot. So the pudendum, which is where the term pudendal nerve came from. So this is the pudendum, and let's learn the parts of the pudendum. First, the mons pubis. In males and females, but more in females, there's a fat pad that covers the pubic symphysis because humans are one of the few species that has sex in which the pubic symphyses actually smash into one another. And so the females have a fat pad, the males have a smaller fat pad, and it's called the mons pubis, which basically that means the pubic mountain. And then the labia majora and the labia minora. So the labia majora are here, and the labia majora are homologous to what male structure? The scrotum, exactly. They're homologous to the scrotum. And after puberty, generally, both the scrotum and the labia majora are going to have hair associated with them. The hair is both protective and tends to concentrate scents. Yes? Which doesn't sound fantastic for a human, but animals really like that. Really, really attracted to the concentration of the sexual secretions. So, and then the labia minora here. Labia minora are homologous to what male structure? Remember? It is the skin covering the shaft of the penis. So I don't want to say it's homologous to the shaft of the penis because the erectile structures within the shaft of the penis are homologous to something else, and we'll get to that in just a second. So, and then inside the labia minora is what we call the vestibule, which means waiting room. Yes? So there's the waiting room, and here's the doorbell right here. That's the glans clitoris. That's important. So here's the waiting room or the vestibule. There's vestibules a bunch of different places. You got vestibules a whole bunch of different places. Here's one vestibule. Inside the vestibule, so the labia minora, inside the vestibule is the opening to the urethra and the opening to the vagina. Okay, so this is the external urethral orifice or the urethral opening. And this is the vaginal orifice. That is not the vagina. The vagina is a tunnel. That's the vaginal orifice. Okay, so that's the opening to the vagina, and we'll talk about that in just a minute. Okay, so in addition, there's a couple of things that you might not know are actually associated with the vestibule. And one of them is that there is the opening for these glands called the greater vestibular glands. The greater vestibular glands are homologous to the male bulbourethral glands. Can anybody remind me what those do?
Change the pH.
They change the pH of the urethra, and they lubricate the tip of the penis upon arousal. So that secretion occurs before ejaculation. It ends up becoming part of the ejaculate, but it occurs before ejaculation. I'll remind you where those are in the male real quick. Okay, so in the male, they're right here, bulbourethral gland, and it's a clear fluid that is going to cleanse the urethra, change the pH, and lubricate the tip of the penis upon arousal. In women, you have a homologous gland, and the homologous glands are the greater vestibular glands. In this picture right here, the greater vestibular glands are kind of tucked back behind. They secrete at the opening of the vagina, at the bottom portion of the opening of the vagina. They are homologous to the male bulbourethral glands, and they will lubricate the opening of the vagina upon arousal. Again, this is not during a climax. This is long before a climax. Good? So those are homologous glands as well, and they secrete right there. Okay, the other thing that's in there is you're going to meet the first of your erectile structures. The first of your erectile structures is behind the skin, right here in the vestibule, and they're purple right here. Do you see them? They're called the bulbs of the vestibule. A lot of times people consider these part of the clitoris, but the clitoris isn't really just one thing. It's the female erectile structures, right? And so, like, I've got them right here too, the bulbs of the vestibule. The bulbs of the vestibule go lateral to the opening of the vagina. They're the first erectile structures that we've met in the female, and what they do is they become engorged with blood, again, upon arousal. And so what would that do to the opening of the vagina, looking at the anatomy? It tightens the opening of the vagina. And tightening the opening of the vagina is pro-sensation, which is pro-ejaculation, which is pro-reproduction. Yes? That makes sense? So that's what those structures do right there, the bulb of the vestibule. They are homologous to the male corpus spongiosum. Okay, corpus spongiosum ends up surrounding the urethra in males. It doesn't end up necessarily surrounding the urethra in females, but it ends up lateral to the vagina. That makes sense? Okay, so those are the bulbs of the vestibule. The other thing that is there, at least in some women, and is not in your textbook because people are still arguing about how often it exists and how common it exists, how much of the tissue there is that, so if this were a male, can you agree that the prostate gland would be right here? Yeah? Okay. So in at least some women, and there's literature out here about it as well, in at least some women, there is glandular tissue right there. It doesn't encircle the urethra, but it's between the urethra and the vagina. And these are called the Skene's glands or paraurethral glands in women. And they are in the women that they exist in, and we don't know how many women have this tissue, homologous to the prostate gland and responsible for the legendary female ejaculation. When female ejaculation occurs, it does not leave the vagina. Like in a male, it leaves the urethra. So when the woman climaxes, there will be fluid that leaves the urethra. So how the hell do you know it's not urine? Well, all you have to do is a chemical analysis on it to figure out the concentration of urea. There will be some. There is in the male ejaculate as well, okay? Versus PSA, which is prostate-specific antigen. And in the women who have this, it has a high concentration of prostate-specific antigen and a low concentration of urea. So how many women have the capacity to ejaculate? We literally have no idea because the literature is still arguing about whether it's even a thing. They're also arguing about whether some erectile structures in women are still even a thing. Okay, so that's the periurethral or Skene's glands. They exist at least in some women. There's a whole Discovery Channel special about it, about female ejaculation, and they do the chemical analysis on it and everything. So it's kind of interesting. Okay, so we did the bulbs of the vestibule, and now we move to the clitoris. The clitoris, again, can be called not just the clitoris, but the female erectile complex. And sometimes they usually include the bulbs of the vestibule in it, and then these structures. What I want you to understand is the bulbs of the vestibules are homologous to the corpus spongiosum. The rest of the erectile structures are homologous to the corpora cavernosa in the penis. So most people know how a penile erection occurs because it's just basically hydraulics. So if you look, let's start with the penis, then we'll go back to the clitoris okay. So if you look at the fact that you've got these erectile structures right here that are smashed back against the pubic symphysis, do you see that? And they go behind the pubic symphysis. And it's kind of like a pool float. So imagine that the pool float is sitting against the wall, right? And it's stuck against the wall here. And then you start to blow up the pool float. And when you blow up the pool float, what's going to happen is it's going to use this as leverage, right? And then the thing is going to straighten out, and then you have an erection. That makes sense? So you can see how this anatomy sort of works with the penis, and then you can go back to the clitoris and know that it's basically a small-scale version of the same thing, right? Okay, especially if you look at it in more detail, and you can see that it actually goes far further back than just what you see mid-sagittally, right? So what you're going to see with the erectile structures of the clitoris is they're mostly internal. So when you are looking at the clitoris, this is what most people assume is the clitoris, but that's just the glands of the clitoris. It's like an iceberg. Most of it is actually behind the body wall. You're not actually going to see it. It is easier to find when the woman is aroused than when the woman is not aroused, right? Because it will actually become engorged with blood. And then it's actually going to stand out. It is partially to completely covered by the prepuce, which is a fold of tissue that covers it partially to completely. The prepuce is usually moved back when the woman is aroused. And so it's only really been consistently published and consistently understood by the lay public as of 2009, because the way that it was represented was purposely removed and misconstrued due to cultural considerations. Over and over again. I told you Gray's Anatomy, which used to be sort of the Bible of anatomy before we had ubiquitous textbooks everywhere. They removed it in the 1950s because it was a very, very conservative time. Came back, removed it in the 1980s, and now the internet is around. So remove it if you choose, but people are still going to figure out that it's actually there. It's homologous to the male penis, the erectile structures, but of course it doesn't have the urethra within it, right? And other erectile structures. It does have a glands. The glands of the clitoris has 8,000 sensory nerve endings, and the cerebral cortex real estate that it gets is the same amount of real estate as for the glands of the penis for a much smaller structure. So that's kind of interesting to think about. It has a body. It doesn't have a urethra within it. It's got erectile tissues, and it's got paired corpora cavernosa. And so what you see is just like with the penis, this is the body of the clitoris, and it's got the paired corpora cavernosa, and then they go back and they're connected to the crus, or crura is plural, of the clitoris. So those are all together. And again, the erection occurs in the same way with the clitoris. Does that make sense to you guys? Everybody good? Okay, so let's take a minute and talk about some cultural considerations of the clitoris. And we'll talk about similar stuff with the penis. In some cultures, historically and still to this day, one of the ways that you can control a female's sexual activity is by removing the clitoris. And so it still occurs. They call it female circumcision, female genital mutilation is what they are doing. And how much of it do they remove? It depends on where you're talking about. They usually remove the glands in the body of the clitoris. A lot of times they can't get to the internal structures of the clitoris. And this is very often culturally done to young girls by the females of 1 and 2 generations older than them. And in some cultures, women are not considered marriageable unless they've had their clitoris removed. And so you can imagine that it would probably be relatively effective at controlling female sexuality because that's where a lot of the pleasure is from. In addition, quite often they will sew up the opening to the vagina so that it makes it so that she can menstruate, and it will be more pleasurable for her partner, but it's less pleasurable for her. So that's all involved in sort of female genital mutilation. Now, we will also talk about male circumcision. One of the things I want to tell you about female genital mutilation is that there has never been any medical necessity even considered for female genital mutilation. And now, with male circumcision, which some people do consider mutilation as well, now we know that it's not necessary medically, right? Historically, it wasn't done as a means of sexual control. Now it's really culturally ingrained, and we're sort of deciding whether we want to switch. It's not medically necessary any longer, but we will talk about that when we get to it. So that's the clitoris. Okay, and now we are going to get to the ovaries. So ovaries, I don't know, to me, when I first saw them in a cadaver, I was kind of amazed at A, how small they were, right? Caused like a world of drama. And also the texture. The texture of the ovary is like large curd cottage cheese. Like they're all weird and lumpy looking. And also by looking at how they're connected, you can kind of misunderstand what they do. And anatomists did for a while. A lot of times they thought that this was a tube, that this is actually how you got from the ovary to the uterus, but that's not. That's a ligament. This is the tube, but it's actually not connected, right? It's just sort of sitting on top. So if we look at the ovary, they are, of course, homologous to what male structure? Yeah, homologous to the testes, and they have two primary functions. They produce gametes, and they produce estrogen and progesterone. And strange little design is that, again, they don't come directly into contact with the uterine tube. In high levels of progesterone, wow, it's snowing hard. In high levels of progesterone, the fimbriae will fold over the ovary, but it's not sealed. And you don't actually ovulate into the oviduct. You actually ovulate into the peritoneal cavity and hope for the best. And in addition, it's kind of a weird structure. So you're actually looking at the posterior view. So if I were the uterus, I would actually have to reach back to find the ovaries back there. So they're kind of back there. Does that make sense? Okay, so the blood supply to the ovaries is from the ovarian arteries, which are actually the gonadals. Where do those branch off of? Yeah, the aorta, abdominal aorta. And then there's also another branch that you guys didn't learn, but just so you know, there's a branch off of the internal iliac that gives rise to the uterine, and then that gives rise to the ovarian. Nerve supply, they've got autonomic motor innervation. They've also got sensory innervation. Some women can feel it when they ovulate. It actually busts through the wall of the ovary, and you can feel it like a pinch. And then let's talk about the tissue layers of the ovary, and then we'll talk about the function of the ovary as we go through. So if you look at the tissue layers of the ovary, if we did a section here, so what we are going to see is that you've got this outer portion. This outer portion is epithelial tissue continuous with the visceral peritoneum. It's called the germinal epithelium, and the germinal epithelium is not even unique in functionality to, like, there's nothing special about it, but that's where ovarian cancer originates. And I told you guys before that ovarian cancer, one of the reasons it's so problematic is because it's really hard to diagnose it properly in the early stages. Because remember, if it just is irritating the peritoneum, it might manifest as indigestion. You might feel like you're ovulating. You might feel like you have uterine cramps. You might just feel like you have a stomach ache, right? And so a lot of times they don't catch it in the first stage. They don't catch it until later. And it occurs in the germinal epithelium. And then deep to that is this layer that you see kind of in that cream color right there. That's connective tissue. That's called the tunica albuginea. They have that in the testes as well. In order for a woman to ovulate, you actually have to bust through that tunica albuginea. And then deep to that, we have the cortex around the outside and the medulla in the middle, okay? And the medulla, basically blood vessels and nerves coming and going from there. So kind of typical, right? But around the outside is where the action occurs. I'm going to hope that you guys remember a little bit about meiosis in order for me to talk about this. Okay, so we are sexually reproducing organisms. Most of our cells have 46 chromosomes, but in order for me to, for instance, make an oocyte that could cause a healthy pregnancy, how many chromosomes should be in my oocyte? 23, so that the sperm can provide the other 23. So what we are going to have to do is we are going to have to start working with these 46 chromosome cells. They are diploid, they're called primordial follicles. You are born with 1 to 2 million of those. Even in Utah, ain't nobody planning on having 2 million babies, right? So you got way more than you need. During a woman's reproductive lifetime, generally speaking, one of these each cycle in an ovary, right? And it doesn't go right, left, right, left, right, left. It just goes right, 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 left, 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 right, whatever. One of those is going to start the meiosis process, okay, in each cycle. And as it does that, it's going to, the supporting structure called the follicle is going to get bigger, but the chromosomes are going to reduce by half and then reduce by half again because you have to go through meiosis 1 and meiosis 2. Does that sound familiar? Okay, so what's going to happen is this structure is going to start going through meiosis, and then it's going to ovulate. When it ovulates, here's what it looks like. This was actually a picture taken by somebody who was taking fertility drugs, and you have to harvest these. And so they did laparoscopic harvesting and actually put a camera in there, and you can actually see this little structure coming out of the side. That's the ovulating. A lot of times women, again, can feel this occur, and it causes a little bleeding when the ovulation occurs. Sometimes there's a little spotting occurred. So that's your little guy that's actually, so here's the ovary right here, right? This is this big developing structure that you're seeing right here that kind of balloons out on the side. And then this little guy is the thing that actually leaves. Does that make sense? So ovary here, and this guy actually leaves. Okay, so you're going to ovulate. That thing is going to leave. And then just to put it back together with the menstrual cycle thing that we talked about. So what's going to happen is right after ovulation, the supporting structure called the follicle is going to stay behind and continue to secrete progesterone for about a week, just in case implantation occurred. Does that make sense? Okay. If implantation doesn't occur, stop. Start the whole cycle again with a different follicle. So let's talk about what you've been told about women and fertility and aging. Okay. So you've probably been told that women are born with all of the eggs that they're ever going to have. And that's not true. What they're born with is all of the egg-producing structures that they're ever going to have. But you have millions of them, and you're only going to ovulate about 400 times in a reproductive lifetime. So what happens to the rest? It's follicular atresia, you just reabsorb it, and it's no problem. Okay? So what is different about males and females, and the reason women's fertility tends to be more associated with their age than male fertility, is that you don't go through mitosis to make any fresh ones of these. Males go through mitosis to make fresh follicles all the time, and then meiosis with those. Mitosis to make fresh ones, meiosis with those. Mitosis to make fresh ones, so these age with you. It is really, really dramatic how difficult a time they have with meiosis as you age. So when you are in your teens and early 20s, the likelihood of having a chromosome abnormality is really low, like 1 in 1,600 to 1 in 2,000, okay? By the time you're 46, and I'm in my mid-40s, it's 1 in 16. So the likelihood of chromosome abnormalities in women increases super duper dramatically as they age. Really important for you guys to understand for a lot of reasons. First off, the more educated you are, the later you'll have kids. The richer you are, the later you will have kids. Okay? So it's really good to understand the risks associated with all of the choices that you make. It's all choices, right? So that is sort of how that actually works. Okay, and then we did the medulla. Okay, as far as what's holding on to the ovaries, again, you're looking at a posterior view here. Go ahead.
Sorry. So you're saying that the follicles, the maturing basically of the oocytes
Yes.
is occurring throughout her life.
Yes. No. Well, no. You have all of these cells, primordia, 1 to 2 million of them, right? Okay, and split into 2 ovaries. And then what is going to happen after GnRH starts when she hits puberty is that on average, one of those is going to be stimulated to go through meiosis per cycle. Yeah? Okay. And so she's going to end up ovulating 1 oocyte it's called an ovum, per cycle, right? And then the next cycle, she'll start another one. But the thing with women that isn't true with men is that these age with her because she doesn't make any new follicles by mitosis. Does that make sense? Okay. And males do. No, it's fine. It's good. It's good. It's good to understand. Okay. So this is one of the reasons, and there's also another reason, just stats. So why a woman in her 40s is more likely to have a chromosome abnormality because whatever she ovulated that month, that's what's going to get fertilized. But males have 350 million sperm per ejaculate. If there was a chromosome abnormality, even if he was 95 years old, that one probably won't win the race, right? So you've got aging and you've also got stats working for males, right? Because there's just so many sperm per ejaculate. Now, am I saying that males do not have an increased likelihood of chromosome abnormalities as they age? They do, but the stats are with them and they're also making fresh follicles all the time, right? Does that make sense to you guys? So it's not true that women are born with all the eggs they're ever going to have, but it's truthy, right? You understand what they're actually trying to say. And it does matter. Okay, as far as the things holding the ovaries in place, here's the ovarian ligament, holds the ovaries to the uterus. Here's the suspensory ligament, and the suspensory ligament is kind of drawn poorly here, but what it is it's suspending the ovaries from the body wall. And then this is the broad ligament that's really supporting both the uterus and the ovaries, right? Sort of holding on to both of them. Somebody in the last class asked, so if a woman has a hysterectomy and her uterus is removed, but her ovaries are still there. So what they do is, of course, they're going to have to remove the ovarian ligament, but they can leave this one in place and they can leave a portion of the broad ligament if they choose to, right? And then some women will actually have their ovaries removed as well. Everybody good? Okay. So we already did this clinical connection, which was ovarian cancer. And now let's talk about the tubes. Okay, so these are called the uterine tubes, or the oviducts, or the fallopian tubes. Fallopian tubes is probably what you learned it as growing up. They're trying to move away from using those words. It's fine that you know that's what it is. So let's look at it in more detail and figure out what it has to do with fertilization and implantation. Okay, so if we look at the oviducts, we will see that there is this cup portion called the infundibulum. It's got these fingers that are called fimbriae. Under high levels of progesterone, again, the fimbriae will sort of fold over the ovary to make it more likely that you will ovulate into the uterine tube. And then this portion right here where it curves is called the ampulla. The ampulla is the most likely place for fertilization, not implantation. Everybody understands the difference between fertilization and implantation? Okay, so the ampulla is the most likely place of fertilization. Then it narrows a little bit as you go through the isthmus. And then this portion right here is called the uterine part, or sometimes the interstitial segment. Good? Okay. If the pregnancy is going to be healthy, fertilization occurs somewhere out here, but implantation does not occur until you hit the uterus. If and when it does occur out here, and we'll talk about some likelihood that that can occur, it can cause what's called an ectopic pregnancy. Ectopic means out of place. And a specific type of ectopic pregnancy is a tubal pregnancy. So we'll come back to that in just a second. So since you actually are not connected, when you ovulate, like I said, you actually ovulate into the peritoneal cavity. But there is what's called the courting of the oocyte. Again, under high levels of progesterone, the fimbriae will close over, but then two other things occur. The smooth muscle in the wall will actually start a peristaltic contraction, creating a wave through the fluid. And then there are ciliated cells. Remember that the oviduct is lined with ciliated cells? Those will also wave in, and they make it way more likely that the oocyte will get into the tube, right? But does it always? No, it doesn't always. You ovulate into your peritoneal cavity. You can have both fertilization and implantation out of the reproductive tract. When that occurs, the woman can have a fertilization because this is not closed to sperm either. Okay, so semen stays in here, sperm swims past the cervix, up the uterus, generally to the ampulla to cause fertilization, but it can keep swimming. And it does, swims into the peritoneal cavity. If it finds an ovum in the peritoneal cavity, it can cause fertilization. If implantation occurs in the peritoneal cavity, you can implant on the bladder, on an intestine, on the mesentery. You can implant on the outside of the uterus, almost without exception. There is 2 journal cases of exceptions. Those cannot be carried to term, and they're generally life-threatening for the woman if she tries. Even a tubal pregnancy is life-threatening for the woman if she tries. And this is important because we're going to have there's some weird politics stuff going on with this lately. I don't know if you guys have heard that. But so what's going to happen is her body is going to tell her that she's pregnant because the implantation occurred and you actually start secreting human chorionic gonadotropin, and if she peed on a stick, she would say she was pregnant, right? But it can't be carried to term, and if it stays there for very long, it can kill her relatively quickly, even in the first trimester. So those are ectopic pregnancies. They generally have to be removed surgically, okay? And if they're in the tube, a lot of times they cause tubal scarring when they occur there. Now, the 2 instances in the journals that show pregnancies being carried to a live birth was 2 that actually implanted on the outside of the uterus because it had access to development of a placenta. Yes? So in both of those instances, the woman carried it into the 2nd trimester, and then it was delivered surgically. And one of the babies lived and one of the other ones didn't. The other one didn't. So interesting thing that I want you guys to be aware that's going on, because a lot of people don't know anatomy and physiology when they try to make political decisions about people's bodies, is that I can't remember which state. Did anybody read it? There is one state in the United States that is trying to impose some anti-abortion legislation that is trying to require women with ectopic pregnancies to trying to force the ectopic pregnancy to try to be implanted in the uterus, which it can. Where is it? Ohio.
Iowa or Ohio?
Yeah, it's one of those freaking I states. It doesn't work that way. You can take it out of wherever it is and stick it in the uterus if you want. It's not going to implant. It's past the stage of implantation. And the woman could die in the process of doing that. So just a little science before you make opinions about science is always a healthy thing. So anyway, so that's an ectopic pregnancy, and we'll talk about some reasons that those occur. As far as the tissue layers of the uterine tubes, the outer layer is visceral peritoneum, and then there's smooth muscle in the wall, and then there's ciliated simple columnar epithelium on the inside. And they also have secretory cells because there's fluid actually in here that helps the movement. All right. Then we did the parts, the cording of the oocyte. Okay, so let's briefly talk about pelvic inflammatory disease and what this has to do with infertility and ectopic pregnancies in women. This is important to understand. So pelvic inflammatory disease is a really, really general term. Basically, it means that something, it could have been an STD, could have not been an STD. Something got some kind of pathogen into your reproductive tract. It doesn't even have to be pathogenic elsewhere. It's just causes problems in your reproductive tract, causes inflammation, irritation in your reproductive tract. It could have, for instance, been a digestive bacteria from somebody wiping improperly, right? But it causes pelvic inflammatory disease, and pelvic inflammatory disease goes from the vagina, right, up into the uterus and can cause scarring of the oviducts. When you cause scarring of the oviducts, and you realize that after fertilization, you start with cell division. So right up in the ampulla, right after fertilization, you will go from 1 to 2, 2 to 4, 4 to 8, 8 to 16, 16 to 32 cell stage. So the developing embryo is getting bigger. If this gets scarred, then what happens is it can't get into the uterus, right? Can you see why that could cause infertility in women? Yeah? Both because the sperm has trouble getting up there and the fertilized egg has trouble getting down. Can you also see why it leads to increased likelihood of tubal pregnancies and ectopic pregnancies? Yeah. So, and the thing that everybody needs to know about this, especially women, is that these are very often asymptomatic. You do not know you have pelvic inflammatory disease until you run into fertility problems or have a tubal pregnancy. So if you want to protect your lifetime reproductive health, you need to protect your reproductive health right now, right? So yes, in your 20s, you're quite often not trying to get pregnant, but you're trying to preserve your likelihood of being able to get pregnant when you choose to. And part of that is by protecting yourself from STDs and STIs, right? and making sure that it's primarily your responsibility to protect yourself from STDs and STIs. Generally speaking, by the way, you probably know this. Well, you might not. You're in Utah. But most STIs are asymptomatic in males. And they're more likely to be symptomatic in females because, so your partner may not think that they have an STI or have ever had an STI, and they had no indication that they did. But your lifetime reproductive health is at stake there. Okay, so now we'll move into the uterus, okay? And the uterus is here, okay? This is the fundus, the part that looks like trampoline, right? This is the body of the uterus, right? And this portion where it starts to get narrow is the isthmus, okay? And then this portion where it actually projects into the vagina is called the cervix, okay? And so the uterus, if we look at it on a mid-sagittal section, you can see where the uterus is with reference to the urinary bladder. In a woman who hasn't been pregnant, it's about the size of a pear. In a woman who has been pregnant, it's going to be bigger forever, right? There was a whole baby in there. It's very, very thick musculature in the wall. Of course, it's smooth muscle. That shouldn't be surprising to anyone. And it's thick-walled. It's got a relatively small lumen except during pregnancy. If we go back to that discussion we had before about why pregnancy actually causes you to have to urinate all the time, you can see that if this woman was pregnant, it would be pushing down on the urinary bladder. That make sense? Okay, and then the supports of the uterus, what keeps it up there, you've got all of the skeletal muscle down here. That's the urogenital diaphragm or the pubococcygeal muscles. It's got some ligaments. The round ligaments are holding it on to the wall, holding it on to the labia majora, and then the lateral cervical ligaments are holding it on to the wall. So let's pull it back here. Okay, and then we have the broad ligament as well. This little guy right here actually goes down through the inguinal canal and inserts onto the labia majora, which doesn't make a hell of a lot of sense in women, but it does in men, right? So it's just a homologous structure to the ones that you have in men. And then if you look at the tissue layers of the uterus inside, what you will see is that this layer right here called the functional layer, that layer develops with every cycle, and then you lose the whole functional layer. And then you develop it again, and then you lose the whole functional layer. So this inner layer is called the endometrium, hence the term endometriosis. And then the myometrium is the skeletal muscle. Smooth muscle. And then the perimetrium is the connective tissue on the outside, also lined with the serous membrane on the outside as well. That makes sense? Okay. So, last little tidbit as we're leaving today is just to briefly talk about endometriosis. Endometriosis is a very, very confusing disorder. What happens is instead of the endometrium developing and proliferating within the uterus, for whatever reason, it's very, very hormonally influenced, it starts to move out, usually into the fallopian tubes first, and then it can move all the way up to the diaphragm. And some of the pain associated with it is that as that tissue starts to grow with every cycle, you will try to slough it off every time your progesterone level drops. And while it's uncomfortable when it's being sloughed off the inner wall of your uterus, it's excruciating when it's being sloughed off the outside wall of your urinary bladder or your intestines or your mesentery. And so it's really, really irritating. And of course, it causes infertility because it irritates the fallopian tubes. And it's really painful and angry looking. Here's a normal female reproductive tract. So you can see the uterus and the ovaries. And here is the female reproductive tract with endometriosis all through. Angry, red, fertility is really, really likely. One of the few ways that we know that actually reduces the likelihood of this causing infertility and can actually cause people to get a respite from endometriosis is pregnancy. So I had a friend when I was in college, and I just started college at like 18, and she had terrible endometriosis, and her OBGYN told her that probably the best thing you could do is get pregnant. At 18. I know they do that on purpose here in Utah, but they do not elsewhere in the United States, I promise you, right? Ain't nobody trying to get pregnant at 18. So here's endometriosis. Sometimes it like confuses your hormones enough that they get back in line, but we do not know how to cure endometriosis. Generally speaking, regulating your hormones with oral contraceptives can sometimes help with endometriosis, and sometimes it doesn't. Sometimes they actually have to go in and do surgery. Sometimes they burn it off and then it doesn't come back, and sometimes even women in their 20s will have to do a complete hysterectomy in order to get rid of it because it just keeps growing everywhere. And like I said, it can grow all the way up to your diaphragm and cause massive, massive swelling and bleeding and pain associated with that, and infertility associated with it. So, and we still don't understand it. It's not a cancer because it respects the boundaries of the abdominal pelvic cavity, and cancers don't respect tissue boundaries, but it's not normally growing tissue either. And it's a very confusing thing to treat. Okay, and then let's get back to the cervix for just a second. So, when we talk, where are we? About the cervix. Okay. So if we go back to the uterus and talk about the cervix, here's the cervix right here. So the cervix's function really is like a gatekeeper to the uterus. Yeah. And the cervix should stay relatively closely closed, except during parturition, which is birth. It's open enough for sperm to swim up there, but semen actually stays in the vagina primarily. It's lined with epithelial tissue. Yeah, but for whatever reason, the tissue of the cervix has a relatively high rate of cancer for an epithelial tissue. So let's talk about cervical cancer briefly. So it's the third most common gynecological malignancy, and it's the 8th leading cause of cancer-related deaths in women, but it's a really, really slow-growing cancer. So as long as you keep an eye on it, you can generally catch it before it's actually cancerous. You can catch it in the precancerous stages. And what they actually do, I forgot to bring it up, what they actually do is they do a scrape of the tissue. I'll show you what it looks like. Just wait right there. They do a scrape of the tissue and they compare the tissue to normal reproductive tissue. And I'll show you what it looks like. Cervical cancer. Where the hell is it? Find it. Hold on. Just wait right there. Oh, there's a cervix. That's also it. This is the cervix post-mortem, immediately post-mortem, and that one's really dilated. So when a woman is pregnant, the cervix should stay relatively closed to hold the baby in there. There it is. Okay. So this is why you want to know your histology. At least you want to know that somebody knows histology. Because when you go in for a pap smear, which was named not for the papillomavirus, but for this guy named Papa Nicolau that figured it out, what they do is they scrape the cervix with looks like a little toilet brush. Not fun, right? It's not. They scrape the cervix, they send it off to a pathologist, and they compare the look of the cervix to the look of a normal cervix. And if you can see these abnormally dividing cells, this is what it looks like when you have an abnormal pap smear. It doesn't mean that you can't have cancer, but it means you have an increased likelihood of cancer, right? So if you have an abnormal pap smear, then you can go in and you can have your cervix scraped. They can burn off the tissue, or they can just keep an eye on you and give you another pap smear relatively frequently. Because like I said, it's a really slow growing cancer. If you catch it early, you can actually live through it, even if it was a diagnosed cancer, but most of the time you'll catch it before it was cancer. So let's talk about this. This one's kind of interesting. So most cervical cancers are associated with an STI. HPV, human papillomavirus, STD, STI, and they stopped using D a little while ago. So almost everybody who's sexually active here in Utah has a form of HPV. The infection rates are about 75% here in Utah. So some of those forms of HPV have a really, really high correlation with both cervical cancer, and this is important for you guys to know because you're not all female, you don't all have a cervix, but you can all carry HPV, and you can all get oral cancers and anal cancers. All of these are associated with HPV, and for whatever the hell reason, we do not know why. Males, when they get oral cancers associated with HPVs, do not usually survive them. The infection rate is really low, but the survival rate is also really low. And that was an interesting one when I was getting my son his Gardasil vaccines, and I had to tell him about oral cancer. And he's like, why would you? And he's like, Mom, tell me no. And I was like, I'm not going to tell you no. I'm just going to let you sit there with that one, and we don't have to have this conversation. So he was just destroyed by it. However, he did get his vaccination. So it's associated with human papillomavirus and STD. Annual pap smears, what they do is they test to see if your cells are dividing abnormally. If they are, then they do an intervention. More than 50% of women who have cervical cancer have never had a pap smear. So you can prevent cervical cancer with regular pap smears. And then, of course, now there is also a vaccine available called Gardasil, which is available now probably for almost everyone in here. Up to age 45, you're still able to get the Gardasil vaccine. And it protects against most form of HPV. And importantly, it protects against the ones that are most likely to cause cervical cancer, oral cancer, and anal cancer. So this is super important because it is damn near the only vaccine we've ever come up with that is a cancer preventative. But guess which state in the country has the lowest rates of HPV vaccination? Utah has the lowest rates of HPV vaccination. We had an interesting conversation with my OBGYN, who's a research doctor. And I was like, what the hell's going on here? Why such a low rate? And he said that when he talks to women, because that's who he deals with, about vaccinating their children, they consistently tell him that my children are not going to have sex until they're married, right? That was the plan for a lot of us. And B, there's another person involved, yes? Another person who might not have had the same plan or the same trajectory as you, regardless of what they tell you. And he told me the sad little part of the story was that the way that he is most effective at getting people to vaccinate is to tell them that their children might be assaulted. And that will get them to vaccinate. So that's the only way he could convince the parents to vaccinate against a preventable cancer. When you're a kid, it's only 2 vaccines. When you're an adult, it's 3 in series. So my husband and I both did them recently, even though it wasn't available when we were kids. Anyway, so that's cervical cancer. You can have that conversation with your partner about vaccinating your kids. I asked my 13-year-old, he's like, why would I want to give anybody cancer or get it myself? And I was like, you're a brilliant person. Let's go do it. And of course, I bought him treats after we got the vaccinations. Okay, so let's talk about the vagina. So here is postmortem photo of the vagina. You can see the rugae in the vagina. And so the vagina has double functionality. Of course, it is the location. Where the hell are you, vagina? Okay. It is the location. It's the birth canal, right? It's the outdoor. It both receives the penis and semen during regular vaginal intercourse. And it has rugae because it needs to stretch, yes? But the rugae have another function in that the friction provided by the rugae increases stimulation on the penis and makes ejaculation more likely. Does that make sense? You need to be able to find it on a mid-sagittal section. Okay, on a mid-sagittal section, here it is. At least 20% of students still, after having this class, will confuse the urethra and the vagina. And that is problematic for a lot of reasons, and we'll talk about one of them in just a second. Here's the vaginal orifice right here. As far as the tissue layers of the vagina, it's really, really woven into the connective tissue down here, right? So it's actually kind of hard to see unless you do a mid-sagittal section or you do a really, really aggressive dissection down there. It has smooth muscle in its wall, right? And then it's got an inner layer with rugae. The inner layer is lined with, remember, moist stratified squamous epithelium, right? And the moist stratified squamous epithelium in the vagina has a special function. And one of its special functions is that it secretes glycogen, of all things. And glycogen, when it hits the vaginal vault, is fermented and keeps the vagina slightly acidic. The acidic vagina is hostile to most pathogens. screw up the acidity of the vagina, you're more likely to get secondary infections, both fungal and bacterial, right? So when the acidity gets screwed up, it's actually more hospitable to pathogens. But it is also hostile to some semen and sperm. Some vaginas do not like some semen. And that's an interesting sort of evolutionary question as to why a vagina might not like some semen. So it causes fertility issues, yes? It can also cause vaginal irritation, right? And so when the semen hits the vagina, if the vaginal irritation, in other animals, we would assume that that probably means that those two are not supposed to reproduce, yes? And in other animals, I can't say in humans, it's a really common mechanism that if two animals are very closely related, then their biochemistry is too similar and it causes reactions and it helps to prevent inbreeding. We don't know why it occurs sometimes between any random two people. Evolution might be trying to tell you something, right? My sister-in-law had this issue with her boyfriend of 10 years. And I was like, he's not even funny. And you shed your vagina every single time. So I think that's all the information we need. So my physiology professor called it the hostile vaginal vault. And he said that some are more hostile than others. And I'm quite certain that's true. Okay, so the opening to the vagina is the vaginal orifice, which is here. Okay, so now, even though your textbook doesn't cover it, let's talk about the hymen. Because did you guys see the freaking TI thing last week? Or 2 weeks ago? You didn't see it? Okay, so he's a rapper, which means he probably did not take anatomy or physiology. I mean, I realize that there are some exceptions. Common's pretty smart. But, so, the hymen. What the hell is the hymen? What's the cultural significance? What's the historical significance? What the hell was the rapper TI talking about? So let's talk about the hymen. All right, so, a hymen is present to greater and lesser degrees in women, and it is a tissue band that partially to sometimes almost completely covers the opening of the vagina. And historically and incorrectly, this is important for you guys to understand, even if your grandpa still thinks it's true, was considered evidence that a woman had not had vaginal intercourse. But I want you to know that there's tremendous variation about A, how it looks from the beginning, and B, whether it would be ruptured with vaginal intercourse, or whether it could have been ruptured with any number of other things. Does that make sense? So did you guys not hear about this? So you did? Okay, so I'll tell you. So the rapper, T.I., I don't even know who the hell he is. My husband plays rap. So he did a podcast the other day in which he proudly said that every year after his daughter's birthday, he makes a gynecologist appointment. She is now 18 to have her hymen inspected and have the doctor give him the report, having her hymen inspected, which is just absolute nuck and futz. Because she's 18, man. Move out, get your own job. Stop putting up with that crap. So, evidence of the fact that a woman has not had sex. It is not that. Hymens, depending on the elasticity of the hymen, may not be ruptured at all during vaginal intercourse. Or they could be really thin and it could have gotten ruptured any number of other ways. Yes? But historically speaking, it has been considered evidence that a woman hasn't had sex for hundreds of years. The Virgin Queen, was it Queen Elizabeth, in order to retain the monarchy, had to have her hymen inspected every single month by the royal doctor, or else she had to step down. So she had never, she had to keep her hymen intact for her entire monarchy. In Western Europe, they used to consider a marriage well made when the woman bled, and so they would hang out the bloody sheet. But here's the truth. Bleeding does not always occur during the first sexual encounter. And some women have such an imperforate hymen or such a complete hymen that they actually cannot have intercourse unless they actually have the hymen surgically ruptured. And this is important to understand because if you have both an imperforate hymen, first of all, if you have an imperforate hymen, you probably have microscopic holes, but you will probably menstruate 3 weeks out of your cycle because it takes a long time to get that tissue and fluid out. A microperforate hymen, you're going to have a long menstrual period as well. But if you have one of these in combination with no education about the reproductive system, and then you actually try to have vaginal intercourse, you might miss, and that's important to understand. So if you have an imperforate hymen, and this is in the literature, you can go to scholar.google.com and see the journal articles about the people who end up accidentally, because both of them were ignorant of the anatomy, having sex through the urethra. Go ahead.
At my job, we do hymenectomies, and so
for little girls,
yeah. So some of the girls are in sports, and they don't want to wear a pad or in swimming or an active sport. They'll come in and we'll do the hymenectomy.
Oh, interesting. What kind of an office do you work at? Oh, I didn't even know they did those things.
They don't come to sleep either. It's
Oh my God. Ouch. So you've probably seen lots and lots of variation in hymen anatomy. Oh, that's really interesting. So, literature. If a girl had a really, really intact hymen and didn't open the hymen, and the male doesn't know that there's 3 holes and not 2, they can end up having sex through the urethra, which leads to incontinence. Of course, it's going to lead to urinary tract infections. And one of the literature articles, a woman was in her 80s and still didn't know why she hadn't ever been pregnant. And sex was incredibly painful for her, not surprisingly. It's transitional epithelium, so it's got a little stretch to it, but doesn't have anywhere near that kind of stretch. So the hymen is not what people tell you it is. It is not evidence that women have not had sex. And there is no corollary, by the way, in males to indicate that males have or have not had sex. You guys good? Any questions? No? And it can rupture by any number of reasons. Okay, so the male reproductive system anatomy. Oh, before we get into that, I wanted to tell you that I put a link at the bottom here that I thought would be interesting for some of you guys. First, sex education information by state I find fascinating. And then the Howard Hughes Medical Institute used a real case and then 3 fake cases to see if you guys can do sex verification in female athletes to figure out whether they are female or male enough, and talked about how it was done back in the 1930s, now, and all of the variations that exist. So this is really interesting because, of course, what if you're XX but you have really high levels of testosterone? Do you get to compete? What if you're XY but you have really low levels of testosterone? So this is like an animation, and you get to pick and figure out whether you put them in the same category that the actual people did, which is kind of interesting. Okay, so the male reproductive tract, reproductive system anatomy. We're going to start that on Wednesday because you guys are ahead of the other class, so I'll let you go spend a few minutes studying for your lab.